Thanks for coming on a Friday. And first, I'm also going to thank Dr. Larzaval, who let me borrow his slides on the treatment of latent TB infection. So I, just as a background, and as Shweta said, so I'm the Director of Infectious Disease and the State Epidemiologist here in Connecticut. But before that, for many years, I have been the medical consultant for tuberculosis here in Connecticut. And so spend a lot of time talking about TB. I love TB. It is one of my favorite infectious diseases. And I do feel really passionate about treating latent TB infection because this is actually how we are going to continue to decrease TB disease in the United States. All right, so this is just an outline of what we're going to talk about today. We're going to talk about planning treatment as adverse effects, treatment options, and there are many treatment options, which is really exciting. Treatment follow-up, and if we have time or if there's any questions, we can talk about just kind of going through a couple of different cases. So, one of the really exciting things is that there are a lot of updated guidelines we get regarding treatment of latent TB infection. So most notably in 2020, and even though it was the pandemic, a lot of things happened regarding TB. A lot of amazing updates happened during the pandemic for tuberculosis. And this one was one of the really important ones. So updating the guidelines for the treatment of latent TB infection. Though before that, the guidelines were 20 years old. So we're really happy that we had that. And so as a companion to the official recommendations, there were the clinical recommendations for actually like how to do this, like how do you actually do a latent TB infection treatment. And then similarly, there are separate but related guidelines for the prevention and treatment of opportunistic infections in persons with HIV. And in that document, treating both TB disease and latent TB infection is addressed. So this is really kind of the basis for a lot of what we're going to be talking about today. So first is kind of pre-treatment. So basically you have your patient that you have diagnosed with latent TB infection, right? So they probably have an IGRA. I think that was last week's discussion. And so obviously the first thing we want to do once we think that we have somebody with latent TB infection is make sure that they actually don't have TB disease. They're actually not sick with TB because we never want to treat TB disease with just one drug. So that is why once we have that positive test, and these days that's usually a positive blood test, it's really, really important that we get that X-ray. And similarly, if somebody is being treated for latent TB infection that was diagnosed many years ago, and we'll talk a little bit about that. It's never too late to treat latent TB infection. That's one of the good things. But if somebody was, say, diagnosed, originally had their positive test 5 years ago and had their chest X-ray at that time as they should, but then for whatever reason was not treated at that time, and now it's 5 years later, and we really want to kind of revisit that idea of treating them, it's really important to get an updated chest X-ray at that time, again, to make sure that they're actually not now have TB disease, which needs to be treated in a totally different way. And if there are any findings on that chest X-ray that are concerning for TB disease, then we really need to kind of go down that path to make sure that there isn't TB disease and do everything that's related to that before starting any treatment for latent TB infection. Certainly, we want to know kind of if anybody has been treated for latent TB infection in the past, and there could be all kinds of circumstances related to that. In general, we don't retreat people for latent TB infection. One of the exceptions to that might be if somebody was treated for latent TB infection in the past, but now has had a new exposure to somebody with drug-resistant TB, that might be a reason to consider retreating them for latent TB infection. Certainly, as we go through some of the treatment options, there are certain considerations in terms of side effects. And a lot of the drugs that we do use for latent TB infection do affect the liver in particular. So making sure that we understand if the person that we want to treat has any risk factors in addition for hepatotoxicity, because that is likely going to influence kind of our treatment decisions at that time. It's really important to make sure the patient is really on board with treatment. And that's why I say it's never too late to talk about that. There's lots of reasons why somebody might not be ready to start on latent TB infection treatment. Maybe they're taking medications that interact with the medications that we want to prescribe. They don't want to have to take a medicine for 3 or 4 or 6 months. So the person really has to be ready to kind of engage in this treatment. And so that's why I always say it's never too late. If somebody is not ready today, when you see them next time, whether it's 3 months later or 6 months later or 5 years later, it's still okay to kind of revisit that idea, because it's never too late to treat somebody for their latent TB infection. And then, the person's on board, they really just need to know what to expect. I mean, a lot of people do really, really well with latent TB infection treatment, which is great. But sometimes there are side effects, and kind of for folks to kind of understand kind of what those are. And we'll talk a little bit about that, but then also kind of what the plan's going to be, and we'll talk also kind of what the recommendations are for follow-up of patients. Okay. So as we were just talking about, it's really important to make sure that before we start latent TB infection treatment, the person does not have any possibility of TB disease. And so this is just part of kind of what should normally be done anyways, right? In terms of, what doing the history and physical, making sure we understand what the TB risk factors are, really going through all of the symptoms that would be concerning for TB disease. So cough, fever, night sweats, things like that. And it's really important to remember that TB can occur anywhere in the body. So obviously, we're always really focused on pulmonary TB, because to get TB in the first place, you have to breathe it in. And so the lungs are always the first place that a TB bacteria enters the person's body. But after that, it can go really anywhere in the body. So it is really important to make sure that we're doing a really good physical exam, looking for enlarged lymph nodes or anything else that could be indicative of potential TB disease outside of the lungs. But we are really focused on the lungs. Again, that is how TB enters the body. And so we want to make sure that chest x-ray is normal. And if there are previous chest x-rays, or persons had, other diseases that has required them to have chest x-rays, looking and making sure there's been no changes to previous ones are really important. And as I mentioned, if somebody is starting latent TB infection treatment further away from their initial diagnosis, it is really important to make sure that we have an updated chest x-ray at that time. These slides say 3 months. I've heard some folks say up to 6 months. So I would say at least you want a chest x-ray within the previous 3 to 6 months to make sure, again, that there's been no progression to TB disease. And then, of course, if there are concerns for TB disease anywhere, then we really need to make sure that we're doing those additional tests, getting sputum if we're concerned about pulmonary TB, if we're worried about lymph nodes or some other part of the body that could be affected, trying to make sure that we can establish a diagnosis before we start any treatment for latent TB infection. Okay. So, as we were just talking about, we want the patient to kind of understand, what are the potential side effects that they could experience based on the regimen that they might be prescribed. So this just kind of really goes over kind of the highlights of those potential side effects that the clinician and the patient should be aware of. So if we're focused on isoniazid, this is, has been the mainstay for latent TB infection treatment for a long time. You'll see that most of the regimens we're talking about are more focused on rifampin, because we can treat people for a shorter period of time. However, if somebody is being treated with isoniazid, we are really focused on potential hepatotoxic effects. So the first thing to remember is that a good proportion of people will have elevations in their liver function tests, just as at the beginning of their treatment. And this is actually normal as long as that elevation is relatively small. And so we'll talk a little bit more about that. So we don't want to react to just the blood tests. We really want to be looking at the test, but also the person themselves. So if the person has a slight elevation in their liver function test, but they're otherwise well and have no symptoms related to that those are usually people we can continue the treatment and we don't have to stop. But we certainly want to make sure that we're keeping an eye on that. A very small proportion of people treated with INH will have clinical hepatitis, and this gets the chances of this increase based on their age and those other risk factors that we talked a little bit about a couple of slides ago, in terms of things that might put people at increased risk for hepatotoxicity, like being on certain other medications, if they drink alcohol, or things like that. And then also, in addition to the concerns about the liver, a very small proportion of patients will develop peripheral neuropathy if they're taking INH. But overall, people generally do really well with INH. If we now focus on rifampin, so rifampin has a slightly different side effect profile. So still can affect the liver, but in a slightly different way. And really focus more on changes to the so hyperbilirubinemia is something that we really look at. Clinical hepatitis increases when rifampin is combined with INH, and that is something to think about because we do have a couple of regimens that do combine the two, and there's reasons that we might want to use both of them. Do see some more cutaneous effects from rifampin, but again, usually self-limited and usually not something that really stops people from taking it. You can have hypersensitivity reactions both with rifampin and rifapentine. So a hypersensitivity reaction usually looks like somebody who might have a high fever, somebody kind of with more of like a systemic effect. Sometimes those folks might look like they have aseptic meningitis or something like that. It doesn't happen often, but it is something that can happen. And then this isn't really like a bad side effect, but people will notice if they're taking rifampin that their bodily fluids, their urine, can look orange. And so again, that's not a bad thing. That's not something that would stop somebody from taking it, but it can be alarming, right? And so it's something that we want to notify our patients about. And then the combination of isoniazid and the rifamycins is something else that can generate its own side effect profile. Interestingly, when the studies were done looking at isoniazid and rifapentine together, there was actually lower rates of hepatotoxicity compared to INH alone. So that's really interesting and helpful. However, a little bit more in those kind of hypersensitivity reactions. So again, that's really the one that we really look out for when people are taking isoniazid and rifapentine together. Okay. So yes, so the overall point is that really in patients that are otherwise well, the benefits of taking these medicines really far outweighs any of the potential adverse effects that could happen. Okay, so what are the treatment options? And as I mentioned, in 2020, we were really excited to have updated recommendations since the previous recommendations for treatment of latent TB infection were over 20 years old. And so this is kind of that latest version of that document. And there are, as you can see, actually many options for treating latent TB infection. And the preferred options are really focused on shorter course regimens. And those are all include a rifamycin, either rifampin or rifapentine. So the three preferred regimens, and these were all evaluated and evidence was evaluated for their effectiveness. And so you can kind of see that here. I'm not going to belabor that too much. The point being is that we're trying to give folks the shortest course that we can, that we think is going to be best for that person. And so you see here, we have 3 months of isoniazid plus rifapentine once a week. We'll talk more about that. We have 4 months of rifampin once a day. There is an option of 3 months of isoniazid and rifampin every day. And then if those are for whatever reason cannot be given, we can do 6 months of isoniazid or 9 months of isoniazid. All right, so again, shorter courses are recommended and really the ones that we want to focus on. So 4 months of rifampin. So what are the advantages? So as I mentioned, definitely less hepatotoxicity compared with isoniazid. It is generally well tolerated. The risk profile, I think, is actually certainly less than INH. And when compared to INH, is as effective in terms of treating somebody of their latent TB infection. And the fact that it's shorter definitely is more likely to be completed by the person. And I don't think that this is like surprising to anybody. If you only have to take a medicine for 4 months versus 6 or 9 months, then it makes sense that somebody would be more likely to complete that regimen. But these studies were done about 10 years ago and it really did show not only is this as good as INH, people are more likely to complete it. And that's really why this is at the top of the list in terms of the recommended regimens. The biggest downside of rifampin and rifapentine is that it does have a lot of interactions with other medications and other medications that people cannot just necessarily stop taking, right? So you'll see on this list, we have things like warfarin, which is an anticoagulant. You have methadone, some of the HIV antiretrovirals. And so it's possible still to take a rifamycin-based regimen But it really takes a lot of coordination in terms of making sure that we're not adversely affecting the effectiveness of the other drugs that the person is taking and needs to be taking. Certainly, if somebody is on oral contraceptives and needs to be treated with rifampin, they need to have a backup birth control method. And there are going to be some situations where people really cannot take rifampin while they're on these other drugs, and those might be people that we have to consider using isoniazid. So here's just kind of a brief summary of what we're looking at. So for 4 months of rifampin, it's in a capsule. You actually take 2 of those. The average dose is 600 milligrams once a day. And it's for 4 months, and the total doses are 120 doses. And that's really important because when we're talking about not just latent TB infection treatment, but TB disease treatment, we're really focused on the number of doses a person takes. So I'll show a table later on about kind of what that looks like, but we're really focused on the number of doses that a person takes. So for example, if somebody, for this regimen, we want the person to take 120 doses. And we don't talk about days because, even with a regimen with 4 months, people are sometimes going to miss, right? And so there is some wiggle room in there, but the point is that we want them to make sure they get all of the doses that they need to get to complete the regimen. All right. So isoniazid and rifapentine. So this is the regimen that is once a week for 3 months or 12 weeks. And the advantages are such that this is essentially one of the shortest regimens that we currently have. And the pills are only taken once a week. So that could be really attractive to a lot of patients. And when this regimen was studied against 9 months of isoniazid, it was non-inferior. So basically, when these regimens are studied, you can't really do like a case control study, right? You can't just say, you can't do one where someone's taking it and then not taking another regimen. So you're really comparing it against a regimen that's already been established to be effective. And so that's why you see kind of that terminology of it being non-inferior. So basically, it's as good as 9 months of isoniazid, which is already pretty good. But because it's a shorter regimen than 9 months of isoniazid, people actually took it and actually completed this regimen more often than 9 months of isoniazid. And as I mentioned earlier, interestingly enough, these 2 drugs together actually had less hepatotoxicity compared to 9 months of isoniazid. The disadvantages are to take these pills once a week. It is a lot of pills. So the average person will be taking 10 pills at a time. And so for some people, that's not a problem, but for some people, that is a problem. That's a lot of drugs to take. I've seen these pills. They are not small pills. So it does take a little bit of time, and some people can, have, a GI upset because of all those pills. The dosing of the pills themselves, so the pills come in 150 milligrams. And so there hasn't been as much work done to kind of get those pills down into smaller doses for kids. So this is not a regimen that really very young kids can take. And similarly, it is not one that we would recommend in pregnancy or necessarily in HIV, but it really depends on what the person's antiretroviral regimen is. As I mentioned before, the side effects or the drug interactions with rifampin are going to be the same as with rifapentine. So they're both rifamycins. They're both going to interact with all of the same drugs. And so all of those same considerations that I mentioned for 4 months of rifampin are the same for rifapentine in terms of making sure that there are not any adverse interactions between this regimen and whatever medications the person is taking. As I mentioned before, while this regimen has less hepatotoxicity, it does have we have seen more hypersensitivity type reactions. So that's more of like that systemic reaction, flu-like reactions. They're usually mild. We have seen people with aseptic meningitis. So usually in those situations when people have that type of reaction, they do have to stop this regimen. And rifapentine, unfortunately, has had a lot of challenges in terms of its availability. And so that has really been limiting in terms of being able to offer this treatment regimen to more patients because the availability of rifapentine has really fluctuated over the last several years. And then the last of the kind of shorter course regimens is isoniazid and rifampin. So this was a new recommendation in the 2020 guidelines for the United States, but it's actually not a new regimen. It's one that has actually been used in the United Kingdom and other parts of the world for a really long time. And so I think part of the reason it was included is that it is a shorter course regimen, and is one that other parts of the world have actually a lot of experience with. And when they actually looked at the data, it does have similar efficacy to 6 or 12 months of isoniazid. Although we do kind of have a little bit less data, I think, than we do with just isoniazid or just rifampin. It is a shorter course regimen, so adherence is certainly going to be better than those longer courses of isoniazid. And the hepatotoxicity, though, with this particular combination of isoniazid and rifampin was similar to 6 to 9 months of INH, whereas, as I mentioned before, for whatever reason, isoniazid and rifapentine has a lower hepatotoxicity. And again, as I mentioned, any regimen that has rifampin is going to have those concerns for those drug interactions. So I would say that this regimen probably has a little bit less utility in the United States because we do have 4 months of rifampin as well as isoniazid and rifapentine. But there could be some situations where this regimen could be helpful, and we can talk a little bit about that later. All right, so we've gone over those shorter regimens, which are all either 3 to 4 months. But there are going to be some patients who cannot take those regimens for whatever reason. So we still have isoniazid as an option. And so for a long time, before these shorter course regimens, which have really kind of taken hold in the last, I would say, 10 to 15 years, isoniazid has really been the mainstay for the treatment of latent TB infection. And it was really in the late 90s that when they kind of reevaluated the data associated with the use of isoniazid for treating latent TB infection, 9 months is a little bit better in terms of effectiveness for 6 months compared to 6 months. So for a long time, 9 months of isoniazid was really the mainstay recommendation. However, when you actually look at how well people completed the regimen, 9 months is a long time to take a medicine, even if it's only one pill. And so you can see here that the completion of that regimen is challenging depending on the situation. Could be as low as 50%, as high as 70%. And so in these guidelines, they really kind of looked at that issue of even though 9 months or even 12 months of isoniazid is a little bit more effective than 6 months, the fact that more people will complete 6 months made that kind of more of the preferred regimen and treatment length if you have to give somebody isoniazid. So really the situations where we're going to offer isoniazid continue to be those where somebody cannot take either rifampin or rifapentine for whatever reason. And so, and again, so that's really, really important. We also might need to use isoniazid if somebody was exposed. We know that they had an exposure to somebody that was resistant to rifampin. So we certainly don't want to give rifampin to somebody who was exposed to rifampin-resistant tuberculosis. And so that's another reason where isoniazid might really be the only option that we have at that time. So just to kind of summarize that, in this situation, because people are more likely to complete 6 months of versus 9 months of treatment, 6 months is really the recommended treatment if we're going to use isoniazid, and certainly really focused on that for the HIV infected, uninfected persons. You could do isoniazid in persons with HIV infection, but when you look at the data for some of those other regimens, again, if they are taking antiretroviral treatment that is consistent with, doesn't have drug interactions with rifampin, we really want folks with HIV to complete a regimen. So we really try to get shorter course regimens into those patients. And then again, there might be some patients who are willing to do the 9 months. It is a little bit more effective. So if they're really committed to that, there's no other concerns for hepatotoxicity or anything like that, that's great. If we can get 9 months into them, that's great. But at a minimum, we want to make sure we're at least getting the 6 months of isoniazid into those folks that need to take it. All right. Okay, so I alluded to this a little bit earlier in terms of kind of looking at the effectiveness of these drugs. And, we have been even though isoniazid was really kind of the focus and the primary recommended treatment for a really long time, there was indirect evidence supporting 4 months of rifampin, and they were in the guidelines that I referenced from 2000. They just weren't kind of like the frontline recommended treatment. So then when they actually did kind of more of those head-to-head, evaluations of these regimens, it really comes down to the fact that people are going to be much more likely to complete a 4-month regimen versus a 9-month regimen. And when they looked at the effectiveness, there really wasn't really a whole lot of difference in terms of more people with rifampin actually completing rifampin and then going on to still have TB disease. That really didn't happen. And again, as I mentioned, we really have much less hepatotoxicity with the rifampin-based regimens compared to isoniazid alone. And so this is eventually what got us to the point where, 4 months of rifampin is considered non-inferior to 9 months of isoniazid. It's much more likely that people would complete it. And that's really why we really focus on those shorter course regimens. Okay, so similarly, when they studied the 12 weeks of isoniazid and rifapentine versus isoniazid, again, they saw the efficacy of the two regimens to be very similar. And so actually, again, very small number of people who are completing any of these regimens eventually going on to have TB disease. That's really the whole point. These regimens are very effective. But again, shorter course regimen, more people are going to actually be able to complete that. And that's really the whole point. If they don't complete the regimen, whatever regimen it is, it's actually not going to be effective. And as I said, more hepatotoxicity with INH alone, more of those hypersensitivity or systemic reactions with the combination of isoniazid and rifapentine. All right. So here's a little bit more information about those hypersensitivity reactions. So we have generally seen this with 3HP, which is the kind of the short nomenclature for the 3 months of isoniazid and rifapentine. Usually after 3 or 4 doses is kind of the average time that we start to see these kind of systemic reactions. As I mentioned before, they're usually pretty mild and those symptoms resolve within 24 hours, but some people have had more severe reactions and that actually require them to be hospitalized. And those are kind of more of those like aseptic meningitis looking pictures, really high fever. And certainly some people have had syncope or low blood pressure. So in those situations, certainly people are going to have to stop this regimen and be changed to a different regimen. Okay. And then, in addition, so when the isoniazid, 12 weeks of isoniazid and rifapentine regimen was first kind of developed, and so almost about 10 years ago, because it's once a week, the focus was really on making sure that regimen was had directly observed therapy. So all of our regimens, when we're talking about TB disease, if somebody is taking those medications, we really want everybody to get directly observed therapy, right? We want to watch them take that medicine. It's so important that they finish their medication. And that is really, really important when somebody is only taking medicine a couple of times a week. Because if you miss some of those doses, that's a problem, right? That's really going to decrease the effectiveness of that. And so when we first rolled out this regimen, we really focused on making sure people got DOT. But there was a study that looked at the effectiveness and treatment completion of this regimen if you got DOT or if you took it on your own. So that's SAT or self-administered therapy, or self-administered therapy with a little reminder to take your medication. And so this was a big, actually multi-country study. It had some people from the United States as well as other countries, and basically kind of evaluating kind of what this looked like. And so certainly the bottom line was that if people got DOT, then they're more likely to actually finish and actually take all their doses. That makes sense. But actually, when they looked at people who were either taking it on their own, so self-administered therapy, or that self-administered therapy with a reminder, there really wasn't a big difference. And so this is really what got us to the recommendation that If people are doing the once a week regimen, they can take it on their own and they don't need to have directly observed therapy. Directly observed therapy is not bad, and there's some patients that might benefit from that, but people can take this regimen on their own without DOT. Okay, so there are a lot of resources out there for patients for taking any of these regimens. And so I'm focused on the ones that you're seeing right now are specifically for 3HP because again, it's only once a week. So it's really easy for people to forget to take their medicine. I know I would forget to take my medicine if I was taking something only once a week. So there are a lot of things that help people do that. And I really highly recommend if you have not been to the CDC website, tons of resources to share with patients and like great infographics, great like medication trackers so people can keep track of it, everything to really help the patient make sure that they're staying on track with their medications. Again, really, really important for folks on this regimen, but I would recommend sharing these types of things for all of your patients because again, it's really, really important that whatever regimen they're on, we really want them to complete it. And so anything that we can do to help them with that is going to be really important. Okay. And then kind of last but not least, this is, I think, kind of the latest regimen that we are talking about. So an even shorter regimen and focused on persons with HIV, but this is 1 month of rifapentine and isoniazid. And so this study actually came out a little bit ago, but again, focused on people with HIV because we know people with HIV, if they have TB, very high risk of eventually developing TB disease if we don't treat them before that. So this is one of our highest kind of risk group patients. We really, really want them to take LTBI treatment. And so this was focused on a 1 month regimen of rifapentine and isoniazid compared to 9 months of isoniazid. And in short, people did better with that 1 month regimen. So really there wasn't a difference between the two regimens. So again, 1 month of rifapentine and isoniazid was considered non-inferior to 9 months of isoniazid in terms of effectiveness. But not surprisingly, also far less serious adverse events. Although not significantly different, you can see that the number of people who had adverse events was less with the 1 month regimen. And again, I think this really goes to the concerns for hepatotoxicity that we have with isoniazid alone. So this is kind of a newer regimen that is an option. I will say I don't know, and I do not treat patients with HIV, so I don't know how often it's really being used in the United States. Partly because the availability of rifapentine has been an issue, but that is another one that's out there. So just to kind of round out that discussion about LTBI and HIV infection, again, we're really focused on getting these high-risk patients through one of these shorter course regimens. So either 3HP, which can be used if people are on antiretroviral therapy that have these medications in them, as well as that 3 months of isoniazid and rifampin, although again, rifampin does have a lot of drug interactions with a lot of HIV medications. So something we have to be careful about. And then we do have isoniazid as an alternative, as 1 HP is an option, again, really dependent on which medications that our HIV patients are taking. And that's really the key here for these patients, making sure that we're not adversely affecting their HIV medication regimen as well. But again, a really important group that we're trying to make sure we treat their latent TB before they get to TB disease. Okay, so in short, we really want to treat our LTBI patients with short course regimens whenever possible. So efficacy is essentially the same compared to isoniazid, got less hepatotoxicity. People are more likely to complete it because it's a shorter course regimen. I think that's all, pretty logical. And as I mentioned, well, I'll hold on to that for a second. And so it's really kind of just working with the patient to figure out which of these regimens is the best for them. Okay, so you have your patient on one of these regimens. And so now what do you do? And so the recommendation really is to see the patient at least once a month while they're on treatment. And there's a couple of reasons for that. So first of all, we want to make sure they're actually taking their medicine, right? And so it's really, if we kind of have that kind of benchmark of like once a month, seeing them, going over, all right, did you actually take all your medicine? Are you having any side effects, anything bothering you? Are you actually keeping track of like that you're taking your medicine, making sure they haven't developed any new symptoms, that could be concerning for TB disease. That doesn't happen very often, but making sure that that hasn't happened. If this is somebody that would benefit from doing monitoring because there are concerns for hepatotoxicity or anything like that, getting those tests done, making sure they haven't added any medications to their regimen that could, adversely interact with, say, a rifampin if they're on that. And so in a perfect world, we're giving somebody a prescription for 1 month at a time. So again, that gets that person to come back, gives you an opportunity to actually talk to them, make sure that everything's going well, and then you give them their next month of medication. But it's also a time just to remind folks, like, okay, if you have any of these side effects, depending on what regimen they're on, it's an opportunity to educate them, make sure they know, okay, if I see this, if my skin's turning yellow, if whatever it is, they know that they need to call right away so that it can be evaluated as quickly as possible. So it's really just a good check-in and helps get patients to that completion. All right. And, we've talked a lot about the adverse effects. Again, a lot of people will fly through LTBI treatment with really no issues at all. And there's going to be some people who have really minor issues. So as I mentioned before, some people might have itching or like minor rashes or things like that. Those are things that we can definitely continue treatment through. Also, as I mentioned, especially with the Isoniazid treatment, we expect that some people will have asymptomatic elevation of their LFTs. And if that happens, that is okay. We can monitor that and kind of treat them through that. However, if somebody's, and so it's kind of the benchmark for that is like, if somebody has elevated LFTs that are up to 5 times the upper limit of normal without any symptoms, we can handle that. We can monitor through that and kind of, again, a lot of people will have that initial elevation and they'll come back down. But once people start having elevated liver function tests that are with symptoms, that's really the folks that we're really concerned about and really want to focus on that. And so it's really kind of making sure that usually in those situations, we're going to stop the medication, whatever regimen they're on, make sure those LFTs come down, make sure their symptoms get better. And then it's really a decision with that patient of like, okay, is this a regimen that we want to try again? Or do we really have to consider a different regimen, given that this side effect was more severe or something that the patient doesn't want to deal with? And depending, again, on the situation, if the person has other comorbidities, that really might require, working with other physicians on either investigating kind of what that side effect was about or what the adverse reaction was about. Or again, do we need to make sure that we're not altering their medications for another condition to treat this the latent TB infection? Okay, so I kind of talked about this a little bit earlier, but when we talk about our completion of treatment for not only latent TB infection, but TB disease, we're really focused on the number of doses. So all of these regimens have a specific number of doses that have to be completed. And this is why it's really important that we can help our patients like really track and say, yep, I took my medicine on these days. So that really helps in kind of those monthly checkups to say, yep, in the last month, the person took 28 doses, right? And we're trying to get to X number of doses. And as you can see here, we have that kind of laid out for each of the regimens. And there is some leeway in terms of the amount of time that people can take to get all of those doses in. And so and I'll start at the bottom first, for the 12 weeks of isoniazid and rifapentine, you actually have 16 weeks to get 12 doses in. For 4 months of rifampin, it's 6 months to get 120 doses in, and for 6 months of isoniazid or 180 doses, you have 9 months to get it in. So I will say that I think some of this timing is a little bit arbitrary, and part of this has to do with the fact that we are treating somebody and treating, bacteria that are kind of dormant in somebody's body that are really growing very, very slowly. So we're kind of using that to our advantage in the sense that like we know that this is the amount of medication that a person needs to take to really, effectively address the infection because of just the way TB works and the fact that it's slow growing. It kind of gives us more time. The medication kind of lasts longer, and its effect on the bacteria is not so that we have to like stick to 4 months. And if you don't do all of your 4 months, you have to start over. So we do have some leeway here, which is really good. But again, really, really important to making sure that we are actually counting every single dose and not saying, okay, you finished 4 months, you came back for four appointments and you're done. So this is, really, really important, but also helpful. So people know, hey, if you miss a dose or two, that's okay, right? Just make sure that you're keeping track. Okay, so that was the main part of the presentation today. I did have a few kind of scenarios that we can go through if that is helpful for people, or if people just have questions, we can start there. Shweta, how do you want to handle that? And I'm sorry, I haven't been looking at the chat.
There is a couple of questions in the chat. So
I see, yes.
yeah,
Yes.
I think Michelle said she hasn't seen any doctor use this weekly regimen.
Yes. Yeah, I
Um,
mean, again, I think more people were using it when it first came out, which is I think about 10 years ago now. The availability of rifapentine has really been a challenge. So we've definitely at the health department have had providers call us and say, hey, I started my patient on the, once a week regimen, but so then they took a month of it, but now I can't get rifapentine anymore. So I think that has really been a part of the challenge for that particular regimen. And I would right now recommend that if a provider wants to use that regimen, make sure they actually have 3 months of rifapentine available before they put that patient on that regimen. The second question is a really good one. So I'll just read it. If one regimen is started and the patient develops adverse effects at the end of the first or second month and the regimen needs to be changed, do you count what was given or complete a full new regimen? So this is always a really good question, and I will say that there's a little bit of debate on this. Personally, when people ask me this question, I usually recommend that you start over. And I'm, full transparency. Some people don't feel that way, but generally, I do kind of say, look, if you're going to start a new regimen, you really want to make sure part of it is I think it's hard to be like, okay, you started one regimen and you took this long. So like say you started on Isoniazid, but you only got through 2 months. Or actually it's the other way around. It's kind of like you started one regimen and you're only supposed to take 2 months of it. But now you have to switch to Isoniazid. Do you only need 2 or 3 more months? In a lot of ways, it's just easier to just start over and be like, okay, this is how many doses of this medication you need to take. And we need to kind of get you to that point, as opposed to not being sure kind of how to translate one regimen to another regimen. So that is usually my recommendation, that people start over if they have to switch. Yeah. Any other questions?
I don't see any other questions. We do have quite some time, so
Yep.
if anybody has any questions, you can definitely unmute. Or if you have any
Yes. And so,
comments, yeah.
yes. And so I have, these are Dr. Larzabel's scenarios, but I think they're good ones. And I'm happy for people to kind of pipe in if they have any suggestions for kind of which regimens they would want to give people in these different scenarios. So how about the first one? You can put it in the chat too. So you have a 50-year-old man with atrial fibrillation, has latent TB infection, they're on Coumadin. What do we think the best regimen is for this person? I know there's opinions out there. So this one's pretty straightforward. Rifampin, any of the rifampin, rifamycins are going to interact with Coumadin. And so this is unfortunately a patient that we usually can't use a shorter course regimen. We really have to focus on Isoniazid. All right, I see another question. So LTBI guidelines recommend chest X-ray for patients, but we have all seen patients with normal chest X-ray and abnormal CAT scan. What is your threshold for ordering CAT scan for LTBI workup? Okay, so this goes not just for latent TB infection, but TB disease. You should be able to diagnose just about any pulmonary TB with a chest X-ray. So the problem with the CAT scan is that, it's really what a CAT scan does. A CAT scan is a much higher resolution. You're going to see all kinds of stuff that you might actually, once you see it, once it's there, you kind of have to chase it down. And I will tell you that a lot of times in a CAT scan, people end up chasing things that are totally separate from TB and may or may not actually be a problem for the person. So that is why for latent TB infection, like again, focus specifically on this person has a positive skin test or a positive blood test. You're just trying to make sure that they don't have, anything like obvious on that chest X-ray that is of concern. But again, you're not just doing a chest X-ray, right? You're doing a physical exam. You're doing the history. You're doing all those other things. And if somebody says something that has you concerned or is like, oh, yes, in the past, I had an abnormal X-ray or abnormal CAT scan, then those are probably the people that you are going to have to probably get that CAT scan. But for the otherwise young, healthy person, never had a chest X-ray before, you're just looking, making sure that they don't have any concerns for TB disease. They have no symptoms, no other medical problems. I would just do the chest X-ray and I would not do CAT scan. So it's really if there's a concern for something else, either based on symptoms or history, that you would do a CAT scan in that situation. Okay. So next question. 40-year-old woman with HIV infection on an efavirenz-based antiretroviral regimen and LTBI. So again, this is a really high risk person. Persons with HIV infection and TB are at their risk of eventually their TB becoming TB disease, so where they're actually sick, is 10% per year. Okay, super, super high. So the otherwise person who is otherwise healthy, is not immunosuppressed, doesn't have any other medical problems, their chances of breaking down from latent TB infection to TB disease is up to 10% in a lifetime. So this is why we really, really want our HIV patients to complete a treatment who have TB. First of all, need to have a TB test, but then also if they have TB, to make sure that we're treating their LTB infection. So important. And so it really is, I think he put this one in here because I think this could be somebody that could benefit from the 1 month Isoniazid and rifapentine regimen that I mentioned. And then again, I'll be honest, I am not an expert on the antiretroviral treatments, but it's really looking at those drug interactions and making sure if we can get a short course regimen into this person. Okay, another question. What is the dose computation for the rifapentine used in the 1 month rifapentine INH combination? That is a good question. I would have to look. My guess is that it's the same as it is for 3 months of rifapentine, because it's weight based in terms of how much rifapentine you get. So the average person, if they're like over 110 pounds, is going to get 900 milligrams of rifapentine. For the 3 month regimen, I would have to double check that for the 1 month regimen, but so that ends up being 6 pills, right? So it's 900 milligrams, 150 each, plus the Isoniazid. So that the average person for the 3 month regimen is on 900 milligrams of rifapentine. I would have to look to see what it is for the 1 month regimen. Okay, next scenario. 25-year-old man with newly diagnosed latent TB infection who had a known exposure to a coworker with Isoniazid resistant TB. So, this is a person where really the best option is going to be 4 months of rifampin. It's not only short course, but they can't take Isoniazid. So it really doesn't make sense to give, it won't be effective, right? Because they were exposed to somebody with Isoniazid resistance. So really our only option for that patient is going to be rifampin, 4 months of rifampin. All right. And then finally, we have a 67-year-old woman with latent TB infection who does not like taking pills. Okay, so I didn't talk a lot about pill burden for these regimens. So for isoniazid, it is 1 pill every day for 6 or 9 months. For rifampin, for 4 months, it's 2 pills a day. And then as for the rifapentine one, it is upwards of, like, depending again on how many rifapentine pills they need, it is a lot of pills. It can be depending on how big they are, like I said, 7 to 9 pills. So I would say that the 3 months, and then if you're doing isoniazid and rifampin together, that's 1 isoniazid and 2 rifampin, so that's 3 pills. So certainly the once a week regimen is probably not one that this woman would be interested in. And so really it's looking at, okay, ideally, again, if she would be willing to take 2 pills once a day for 4 months, for the rifampin regimen, that would be ideal. But if she really does not like pills, then I think that this could be someone where 6 months of isoniazid would be the one to go with. And again, a lot of these discussions, again, it's great that we have options because we can like really work through those options with our patients as well. Any other questions? And then actually, let's make sure I didn't forget something in my guess. I did have yes, I did.
Lynn,
Okay.
forgive me if I
Yes.
missed this.
What's that? I can't hear you, Shweta. Sorry. I'm going to stop sharing my screen.
Hi, forgive me, I'm so
Oh, that's
sorry.
okay. That's okay. I can hear you now.
My Zoom just crashed. I
Oh,
apologize. No, it's the question, the Carolyn Simpson's question. Are there any recommendation to hold NTBI for contacts until index case sensitivities come back? Was that answered?
got it. Thank you for pointing that out. I did miss that one. Sorry about that. So generally we don't. And so part of that is that if all is going well, almost all of our patients will have a nucleic acid amplification test at the time of diagnosis. So our TB disease patients. And that is really helpful. It's basically a PCR on sputum to, first of all, identify if TB is present. And if it is, it can also tell us if there's rifampin resistance. And so since so many of our patients are getting that test, at least we know up front if there's any concerns for rifampin resistance. That said, we do not really have the same test for isoniazid. And so again, another reason really to really focus on the shorter course rifampin-based regimens, because for most of our patients, we're going to know upfront if there's concerns for rifampin resistance and whether we need to make different recommendations for contacts. But if we're starting a rifampin-based regimen and then we find later on that the person is isoniazid resistant, that's still okay because we've been treating the person with a rifampin-based regimen. So I think it's just another reason that we really try to focus on those rifampin-based regimens as much as possible. And we generally, if we're doing a contact investigation and we find that any of those contacts do have latent TB infection, that is another very high risk group. Their risk of your risk of breaking down from latent TB infection to TB disease is highest in the first 2 years after infection. So that's why we really want to make sure that we're not only identifying them, but getting the folks that are infected on treatment as soon as possible. We really don't want to delay if we can. All right.
And there's another question from Marina
Yes.
Glasgow.
Yes. Is there much appetite for alternative regimens for latent TB, i.e. 9 months of fluoroquinolone or 4 months of rifampin when standard options can't be used? Okay. And then I see that there's another question about suggestions for context to a multi-drug resistant case. So I think the answers to this sort of go together a little bit. So the recommendations for multi-drug resistant TB and kind of the standard definition for that is at least resistance to isoniazid and rifampin. So the current recommendations is anywhere from 6 to 12 months of a fluoroquinolone is really kind of our go-to and is part of the standard recommendations now for persons with multi-drug resistant TB. Now, that said, if somebody has more resistance to that or somehow is, say, known to be exposed to somebody with a fluoroquinolone resistant TB, luckily relatively rare. In my time here in Connecticut, I think we only had ever one person, maybe two, with that situation. Then it's really going to be important to consult with some TB experts, me or the folks at Rutgers, kind of what the right thing to do. And usually in those situations, we are using the resistance profile of the TB disease case to kind of come up with usually a 2-drug regimen for those folks. So that said, kind of to go back to Marina's question, we really try not to go outside of the kind of standard recommendations for treating latent TB infection. We're really focused on isoniazid or these rifamycin-based regimens because, again, first of all, we don't know the effectiveness of any other regimens that we would come up with. The fluoroquinolone regimen for multi-drug resistant TB has been studied, and so that was kind of like a expert opinion regimen for a really long time, but now is part of the treatment guidelines. But any other regimen we come up with is going to be a little, it is going to be expert opinion. And so we really don't want to do that. We really want to try to stay with the ones that we know are most studied. And so that said, there are certainly opportunities and, occasion where somebody might decide to do something a little bit different. But again, I think everyone has to recognize that if you go on to one of these other regimens or decide to do a regimen that's not studied, recognizing that we might not understand really the effectiveness of that regimen. Yes, and I highly, highly recommend the consultation service at Rutgers. If I don't know the answer to something, those are the folks that I reach out to, and they are super helpful and really, really appreciate all of their help.
Thanks, Lynn. And I do want to mention later this afternoon, we have a case presentation also from Connecticut that was actually sent to us through the medical consultation database. So if you're not joining the Grand Rounds presentation, I will share the link. Definitely register and join. That'll be definitely while you have some information.
All right. So sorry, Shweta, I know I talk fast, but I hope it was helpful. And again, thanks to Dr. Larzabal for letting me use his slides. They're great.
Thank you again for joining. Again, Lynn, if you're able to share the slides from today.
Yeah, I'll send them back to you. I just made one. Honestly, okay. You could, if you have L slides, they're basically the same.
Okay, no problem. And they will be shared by next week's session.
Okay.
And the recording will also be shared. So thank you so much again for joining, everybody. Definitely stay tuned with us for upcoming sessions. And hope you have a nice weekend.
Thank you. Bye.